Good morning. Thank you for coming. I'm surprised that you all have managed to come at 8 a.m. I thought it would be half of this. This is great. It's a real pleasure to be here at the ASA Refresher course to speak with you about a topic that touches the heart of our profession, ethics and integrity in anesthesiology training. My name is Shala Siddiqui. I'm an associate professor of anesthesia and intensive care at Beth Israel Deaconess Medical Center, affiliated with Harvard. I'm also the co-chair of the ethics committee there, and I've started an ethics curriculum amongst our trainees for the last 1 year, and that's what I wanted to share with you. My interest in ethics started early in my career when I realized that the hardest clinical decisions that we make are not about physiology and pharmacology, especially in critical care. It's more about the values, communication, and moral courage that we often have to face. We often talk about ethical erosion, and this is the gradual decline in empathy and idealism. When trainees come in, they have all of that, and then as they progress through medical education, we've seen, and this has been documented in various studies, that there is an erosion in those values. Many start with a goal to help people, but by the end of training, they may feel detached, morally fatigued. And in anesthesiology, where we manage life, death, consent, trust every day, this erosion can be especially profound. Today, I want to share a framework for building a structured ethics curriculum for residents, one that moves beyond theoretical discussions around ethics, but more into the lived reality of our training environments. We'll look at why ethics matters, common dilemmas our trainees face, and practical strategies for teaching and sustaining moral resilience. There's a lot of work that's gone into this on the nursing front. And they also have a lot of support for sustaining moral resilience. But there's very little, and I'll share the literature with you, within medical training, and more so within medical profession. So when faculty, and most of you may agree with this, that when you became attendings, suddenly that support structure just fell away. And the moral resilience and the moral injury that you face in daily work often leads to burnout or other things. So we look at why ethics matters, how do you teach, sustain, and assess moral resilience. And ultimately, this is about cultivating clinicians who are not just technically excellent, but also compassionate, reflective, and trustworthy. And I hope this session gives you tools and ideas to take back to your programs, because ethics training is not optional. It's the foundation of professional integrity and identity in anesthesiology. So with that, I just wanted to start the slides. I have no conflicts. Sorry, it's not moving. Is there a mouse up there? There is. I was hoping the remote would work, but it's not. There we go. Okay, so I have no disclosures for this talk. I wanted to share this. I don't know if any one of you reads the Forbes newsletter. This one is written by Sachin Jain. Sachin Jain is a Harvard-trained physician who now works in California. He has his own startup. It's a think tank around health policy. He used to be a transformative leader in CMS, and then he got very disheartened by the direction of healthcare and health policy and left CMS. He wrote about the ethical erosion and deafening silence of America's healthcare leaders. And he described ethical erosion as the gradual decline in values, beliefs, and truths. In this article, he states that incoming medical students presumably carry pure values. As they write in their medical school applications, they express a desire to help people. However, by the end of their training, they are sometimes found to be hardened and less empathetic than they were initially. The medical student who once hugged his suffering patient may later in his career fail to make eye contact with a patient or return a phone call. Those are the small slights that we see every day. We may carry them out ourselves, and we don't even notice it because it's part of our normal day. It's part of the learned behavior that we have espoused. And it's probably the most practical thing that you can do is just to meet someone for 5 minutes in the clinic, move on, or in anesthesia, we go get a consent. We don't realize how important that moment could be for that patient and their family. And as we go through the slides, because it's 45 minutes, I'm going to stop and share stories with you. And I want you at the end to tell me your stories as well, because ethics is really a habit. In Greek, ethics actually comes from the word ethos, which means habit. So it's not something that is outsourced to the ethics committee in your institution. It is something that each one of us has within ourselves. And we reflect on it and think about it. So as I structured this curriculum and I continued to teach the students, actually the residents, I started getting an overwhelming response to have more sessions. And residents would come up to the program director and say that, they really need this as a sort of catharsis for the daily work that they do and the daily battle that they have within their own morality in the type of clinical care that we set out for them and the set of values that they came in with. At some point in our career, all of us have had that jump from the idealistic person or professional that we imagined ourselves to be. And I'm not saying we are unethical in any way or immoral. I'm just saying that we are not that idealistic portrayal of who we want it to be. And that's what this curriculum hopes to kind of integrate. So the story I wanted to share with you is that I had a CA1 resident. A patient came in for an emergency surgery. It was a very sick patient, but she was awake in the pre-op holding, but it was emergent, needed to go in. And it was a ruptured tumor in her colon, was bleeding, needed a laparotomy. The family were called in. They were in the pre-op holding area. We have curtains in our pre-op holding area. We pulled the curtain, let the family in. But the surgeon was very eager to go in for the right reasons. Patient's pressures were fine, but she was tachycardic and she probably was bleeding and needed to go in. The scan was horrible. It was the first time that they noticed she was a 79-year-old lady, but otherwise healthy. And they noticed that the scan showed that there was tumor everywhere. And the chances of her coming out of the surgery, at least completely intact, were very low. She probably would remain intubated on pressors, etc. So we were rushing. The nurse was rushing, trying to get her work done. We were putting in IVs, etc. The family were there, but just lost, didn't know what was happening, not to mention the patient. My CA1 stopped everyone, asked everyone to step out, pull the curtains, and told the family, this is probably, a very important moment for you. We don't know if she'll come out awake. I want you to spend time with her. And he told the entire team to wait 5 minutes because he said they probably won't see her alive again or awake again. And that really shook everybody because this is a CA1 resident. But the amount of moral courage that he showed at that point, and now he's an attending, and every time I see him, I'm like, we still remember that. And that moment was very important. So it doesn't matter who you are, that courage and resilience that you can bring into the equation can mean so much to your patients and your family, the families that work with you. So that was a story I wanted to share, that it doesn't matter who you are, whether you're a leader. At that point, that resident was the leader of our team. So let's go back a little bit to what ethics is. And historically, ethics and professionalism in anesthesiology training are very closely intertwined since the time of Hippocrates and then finally Thomas Percival when the actual code of ethics was made. We talk about residents facing daily dilemmas, but we have an ethical code within our profession that dictates how we are supposed to function. And this comes into the consent that we take, the communication that we have with families, the resource allocation in the ICU or in pain clinics, for example. That's where the big burden of ethical dilemmas come in. The ABA has also has some milestones which are required within the training, where competencies are assessed within OSCEs, within board exam questions, and there's always a question on the oral boards for an ethical dilemma and how do you deal with it. But these are really very small snapshots of actual ethical issues that come in our daily practice, and we are not equipped within that training to deal with those issues. Like I said, going back to the Hippocratic Oath, and then following that, and incidentally, Hippocrates and the Hippocratics, as they were called, I had to, during my master's, had to read all about the history of medical ethics. The Hippocratics were a very small sect at that time of physicians who practiced good, virtuous medical care. The rest of the physicians were not virtuous. They were not required to be virtuous. They were healers, but they also had chemicals. So, for example, there was a Greek queen who had her husband killed for various reasons by going to the healer at that time because he had the tools to do it. So there was no requirement for physicians or healers or people with chemicals to be good, or what we think of as good right now. And one would say that we have come full circle, but at that time, the Hippocratics were the ones who thought about the Hippocratic Oath and talked about doing good and not doing harm. And that's where our medical ethics and our code and Thomas Percival comes into this. So ethics is a philosophical study of moral phenomena, also called moral philosophy. It investigates normative questions about what people ought to do or which behavior is morally right. So normative means that this is how it should be. And whether it is or not is separate, but this is how it should be is what ethics talks about. Medical ethics is the study of moral values and judgments as they apply to medicine. And in the 5th century BCE, Hippocratic Oath was founded, foundation of Western medical ethics. But at the same time, there was a lot of medical ethics being practiced and taught in other cultures, which the Western medical ethics later on espoused. But this was going on in the Islamic tradition, in Confucianism, in the Jewish traditions, and also in Ayurvedic Indian traditions, where there was a code of how to practice. And that code did spell out the ethics codes that we are familiar with now. So this was going on in parallel as Western medical ethics was developing. In 18th and 19th century, there was the emergence of professional code by Thomas Percival's famous document called Medical Ethics in 1803. And of course, in 1947, the horrific Nazi physicians' behavior developed the Nuremberg Code, and therefore the Declaration of Helsinki in 1964, where physicians carried out unbelievably horrendous experiments on humans. So one can have codes in place. The Thomas Percival Code was present at that time when this was happening. But that doesn't mean that ethical behavior will be conducted. There was a bioethics movement in the 60s and 70s, starting from California, where the term bioethics was coined. And of course, then Thomas and Beauchamp defined the 4 pillars of ethics as autonomy, which it really means a person's preference. And that became the most important pillar of medical ethics. And then justice, which is basically fairness. And we saw this taking an importance during COVID, where resources were really stretched and we had to actually triage patients and who would get the ventilator, who would get the drugs, etc. Beneficence, which is really our code, which is doing good. And then non-maleficence. There is a difference between doing good and not doing harm. And if you reflect on it, Doing good is actually going out and doing the right thing by your patient, conducting good clinical care for your patient. But there are times when you think about not doing harm. And sometimes one would say that futile care in the ICU or doing a procedure on someone who may not survive could be not doing harm if you don't do that. So there's a fine line. In medical school, there is an integration of ethics into formal curricula, and that began in 1970. So when bioethics term was coined at Stanford, they started the medical ethics curricula. The first one was at Harvard. And then this continued throughout the year. So medical students are actually taught in a very formal way medical ethics throughout their longitudinal time there. And I teach at Harvard. I teach the first years and the fourth years, and they come in and they bring in so much of their own lived experience and their own reflections. And it's really joyous to see that. When those same students come to me as residents, this is not a priority for them. Reflecting on their day is not a priority. And this is not a criticism. We all were that way. And the reason is because we don't have time. What is being assessed and what is being judged is not what we have grown up developing as a human being. And this is not what is being assessed. We may be a good moral person, but that does not matter in your residency training. So that's why that was one of the big motivation for me to do this for our trainees, is to have an avenue where they can continue to develop the wonderful ethos that they have of good moral character. The AMA's Code of Ethics was first adopted in the mid-20th century and continuously updated. ASA also emphasizes the perioperative ethics, informed consent. We have white papers from ASA and guidelines on patient safety, which is really basically doing good. End-of-life decision-making, which is in collaboration with SCCM and ASICM. And there's a growing attention to professionalism. And I'll go back to that article by Sachin Jain. And of course, as you know, there is a huge erosion of trust amongst the public with medical faculty and the medicine community. Sorry. So the current state of ethics education in the US, most medical schools have now mandated ethics training. But in residency, we did the study where we found that there's only 4 hours per day spent on ethics training. And this is any kind of training. It could be a lecture, it could be a sort of a workshop, or just some discussion on ethics, but at most it's 4 hours across the board in big academic centers. There's an increasing role of case-based learning, simulation, interprofessional education with the nurses, because they have a very robust training in ethics. ASA and ABA refresher courses are now starting to sprout up. There are fellowship programs as well in medical ethics, and PhDs are being offered. CME is being offered for these as well. So as I said, current training, 3.8 plus minus 1.6 hours per year of formal ethics training. 58% of program directors reported that graduates are unprepared for dilemma. So this is not just training. They feel that their trainees, when they graduate as CA3s, they often ask for ethics consults rather than knowing what the right thing. And I'm not against ethics consults. I'm the chair of the ethics committee. I'm all for having ethics consults. It's great if you do. But I think in your practice, you should, like in any other skill, start learning how to solve those dilemmas, or what is the path, and then use ethics committees to execute those decisions. And very often, it's just time and communication that is required. So why do we need ethics? Why ethics training for anesthesia residents? This is what I had to sell to my vice chair of education when I went to them with a vision statement and a proposal. It guides complex decision, informs consent, end-of-life care, resource allocation in perioperative and ICU settings when they graduate and they become independent. It models professional integrity. the whole institution looks at anesthesiologists as the bridge between perioperative, surgical, nursing, ICU, physicians, etc. And we often are, whether we know it or not, whether we like it or not, we are leaders in our own way. And everybody from medical students to families are looking, and many of you may relate to this when you tell a family or a patient, I'm your anesthesiologist in the pre-op holding area, and there's a sudden smile and a relief on their face because they feel that you are the person who will be my guardian angel in that very scary OR environment. And very often those patients look to us for that bond and connection. But very often, and studies have proven this, that connection is not offered. And it's not because we don't have time. It's not because we don't want to, or we, as medical students, the young medical student within us didn't want to. And I've seen my medical students stand back and hold someone's hand and talk to them, or chat about their family, or stroke them if they're nervous. They've done it, and we would have done it, but we rush off and we take care of many things. We don't have the desire to do it. Now, whether we are morally fatigued, or we are less empathetic, or we just don't care, or we are burnt out, or we are bitter, we don't know. But the facts are that that connection is not offered. So we need to be models in professional integrity, demonstrating empathy, transparency, and moral reasoning for our trainees to, again, go back and find that very ethical and idealistic person that they were when they applied for med school. It also strengthens team collaboration, provides shared ethical language for resolving conflicts and aligning goals of care. So this kind of training, we do simulation, we do role play, we actually give words to our residents on what to say in family meetings, in difficult situations, how to break bad news. It ensures responsible scholarship. We have a lot of researchers who do a lot of research in design, in authorship, data handling, how to deal with other peers when they are doing research, how to deal with patients and families. It builds leadership capacity. We used to talk about equity, but now we say egalitarian work that we do. But it helps us build a team which is very cognizant of differences amongst people, and how do we bridge those differences. It equips clinicians to shape their policies and ethical institutional culture. It supports moral resilience. In this day and age, it is very easy to fall through the cracks. We have seen a rising number of trainees and faculty who succumb to substance use, succumb to depression and burnout. A lot of it arises from that inner conflict that goes on within us. So it helps having an avenue for venting that or discussing this with other peers. And I know the residents talk amongst themselves. They have sessions where they discuss these moral dilemma, but they need to have a structure, and they need to have an outlet where they can actually continue this within their training. So that is moral resilience, where you can undergo feelings of dilemma and conflict without breaking your soul or your spirit. And we work in very high stakes environments. We work in high stress situations. I'm an intensivist. And I often see that people are looking at me to sort communication issues, conflict issues, and non-clinical issues in my daily work every day. And it's not a role that I asked for. I don't have a title for it, but they expect that from me. These are the nurses, the families, the patients, even the staff, the medical students. Everybody looks at us for resolving those. And unless we have training in it, unless we have some guidance, there's no way that we can suddenly sprout up and listen to a podcast and suddenly become experts in that field. We learn everything else. I learned how to put in chest tubes, central lines, echoes, transesophageal echoes, swans. Why shouldn't I learn how to deal with communication issues, confrontation, medical ethics dilemma? Now, research is very important. There's been 3,000 papers redacted last year, just in 1 year, on fraudulent data in research. Not just from the US, from across the world, but a lot of it came from the US. So, and these are big journals. These are not the phishing journals where you pay $1,000 to publish your paper. What does that mean? What does that tell you? And also we have vulnerable patients who are, this is not just in the Tuskegee times when patients were allowed to have syphilis and die from it and just observed. These are patients now who are being enrolled in studies and not being told of the potential complications and side effects of the drugs that they're being given. So we have to be very careful. And the more this is in the discourse, it's like bringing up a child. The more you mention in your house something is wrong and something is right, the child will not instill that within their vocabulary. So within training, the more you talk about something as being right or wrong, remember the narrative of ethos, the normative narrative of ethics was what ought to be. So the more you talk about it in your training in a structured way of what ought to be, even within research, and that's why we have the GCP certification, the good clinical practice, and IRBs. But those 3,000 papers that were redacted were by authors who all were certified in CT training. They all read the Helsinki requirement and the Belfast Commission. So, common ethical dilemmas in anesthesiology that we face are perioperative DNR orders. This is from a survey that I did amongst our fellows and our residents. The biggest problem that they have is perioperative DNR orders. What do you do with them? The current ASA guidelines are there should be required reconsideration. That means you don't have to rescind DNR orders just across the board. And I know many institutions do that because the gastroenterologists feel comfortable, the nurses feel comfortable. If someone is full code, what are you going to do if they arrest on the table? They'll hold up the OR, et cetera, et cetera. But it's better to just talk to your patient and their family before you go in that, look, you are DNR, this is by your choice, this is your prerogative. What happens if I push propofol and you suddenly have a cardiac arrest? Would this be within your goals of care? You don't ask them a menu of what would you like, but you have a discussion of what could they don't know what propofol can do. And someone who's just hanging with an EF of 5%, they can die. But what are you going to do? Are you going to perform CPR and possibly VA ECMO if they're full code? Obviously not. You're going to talk to them about the potential side effects. And does this patient who is at this point in life really need this procedure unless they're exsanguinating and they don't want to die with a bleeding GI ulcer? There has to be reason and, again, what ought to be. So that is something that comes with the ethics, emotional intelligence that you build within your trainees and even your faculty. Withdrawal of life support in the ICU is a big one. Again, this depends on so many factors. Depends on not just autonomy, but also your discussions and continuous discussions within the family, the patients, and the goals of care. This is where I do bring in ethics committees, not because I don't know what is right and wrong at that point. It's just that one sit-down family meeting is not enough. You need continuous conversations. It's about somebody's life and values that are brought in by many, many factors, many stakeholders in that committee. And especially if you have, for example, a brain dead patient or someone who's young or someone who had a very traumatic, unexpected death or someone who's on ECMO and now is futile. So things like that need continuous discussion, and one person, one team may be too stretched to do that in a proper way and with the gravity that it requires. And because of that, I bring in ethics committees and the consultants. Surrogate decision-making and autonomy. Now, literature has shown very recently, I just wrote an editorial on this in ANA, on how family members and patients' loved ones actually don't know what the patient's reality of dignity is in the ICU. And this has been proven that they did a survey on patients, and they found that they filled out a dignity survey of what they consider a dignified death. And they chose that they did not consider the care given to them as dignified in the ICU, but the family members thought that it was and asked for it. So very often there's a disconnect between what your patient would have wanted and wants and what the surrogates are asking for or have agreed to. And it is our role to be the arbiter of trying to understand what is the actual goal of the patient. And very often we are not treating the patient, we are treating the family. So that is something that is a huge ethical dilemma and can lead to burnout if you continuously are giving care that you feel is wrong for your patient or against their wishes. Disclosure of errors, this is also, it's very important. How to disclose errors in our very busy lifestyle. Just the other day, before I flew off to San Antonio, I had a resident who did an intubation, was smooth, video, no problem, one pass. And then at the end, when I was extubating, it was a really long case, we were suctioning and we found a lot of blood coming from the oral cavity. Asked the surgeon, who was an ENT surgeon, thankfully, to look in and like, hey, Ted, this doesn't look right. He looked in with his loupes and there was a big palatal injury, which was not apparent at the intubation. Although she used a video laryngoscope, it was a first pass. So we don't know what happened, but disclosing that to the patient was very important afterwards. So he repaired it, dealt with it, a lot of blood loss. Patient had to be admitted unexpectedly. But then we had to go and tell the patients. And the resident said, I'm so glad that you're with me because I had no idea what to say to them. And I'm like, you really don't need too much training in telling somebody that there's been a complication. But I think if it is structured and they know the words or they're given the cues, it becomes easier, causes less trauma. This resident had just come back from maternity leave. She was taking very frequent lactation breaks. She felt very shaky on her feet already, and confidence was could have been lost if at that point she felt that, oh, my first day back in the OR, first week back, I've had a huge complication, and now I have to go tell the patient. And I had 3 rooms that day. If my attending isn't going to help me or walk me through this, my career is over, my confidence is shaken. So it can break people, especially if they're at vulnerable points in their lives or their training. So it's important to have these drills beforehand so that it's part of their practice and their vocabulary. Brain death criteria is also very important. How do we discuss brain death? How do we come to that conclusion? How do we determine it? And then how do we discuss it with family, especially if there's transplantation to take place? And then the impaired anesthesiologist. This is not just ethical, it's also legal. It's also a big topic. It's a big problem within our field because of the access to narcotics and hypnotics. I had 2 attendings in my residency, one during my residency and one afterwards, and he was a leader in his field. They committed suicide by fentanyl. So that's something that has personally affected me and my colleagues, and we had 2 residents in our training programs, and very recently, in Boston. So this is something we have to keep an eye on this. We have to be very cognizant that this may be a problem with people who are just next to us, So we have to, and there's no vilification of these people. These are people who are struggling for a long time. And these kind of structured curricula can actually give them the opportunity to ask for help or to reach out for help. What is the impact? And this again came from that survey. We asked the residents after 1 year of these sessions, what does it mean? What has it done for you and for your patients? And they felt that conflicts between patients, families, and clinicians were better resolved. It helped with compromised moral integrity. It helped with moral distress, knowing the right action, but when they felt constrained, they had an avenue to discuss it or find a way out. And then it reduced moral injury. There's a difference between distress and injury. Moral injury is often irreversible. And it has happened, and it's usually through years of this kind of continued erosion of the medical moral compass. And it's also transgression of deeply held values. Now remember when we were medical students and we wrote our application, we wrote about how we were deeply moved with human suffering and we wanted to help people and help humanity. We all did that in our interviews, etc. And we went for a community service in high school. I've got 2 kids, one of whom is trying to be a doctor. And we've seen years of how they've done community service and gone out and helped people. And I went on medical missions when I was in Singapore. But all of that comes because of a certain deeply held value that we all bring. We are all sort of self-selecting ourselves into this profession, not just for money or the lifestyle or whatever other trappings that come with being a doctor. We are in it for a reason, and that we can't glamorize that, but it's because we really believe that we want to help people. That's our purpose. And when that comes in conflict with the kind of practice that we have to do, for various reasons, some more than others, then there is a conflict and there's a friction, and that can lead to moral injury. Many of us are morally injured, whether we know it or not. So the goals of our curriculum were standardization and evaluation of ethical behavior, building an ethical competence, like any other competence within the ACGME competencies, knowledge, skills, and in this case, I added professional character, which you cannot judge, you cannot assess. I asked the dean at the ethics, the dean who's also the chair of the ethics center at Harvard, how do you judge or assess moral and ethical character in a trainee, in a medical student? And he gave me a lecture for 45 minutes on how we should not. There is no way you can assess ethics. You can teach it, you can discuss it, but you cannot say that someone is ethical or unethical unless they're breaking the actual boundaries of ethical behavior, because it's gray, and all you can do is teach it, bring it in the discourse of your institution and the culture of your organization. And once it's there, it's everywhere. Like I said, in the values of your household, if you have good character espoused by everyone in the household and it's just there, there's no solid or a physical thing that you can say that this is what I'm teaching my kids. It's just there. It comes out in how they evolve as humans. So in everything you do, this kind of ethos or habit will come out. So we visualized this training. We went with a vision statement. We went to the leaders in the department and we said why we want to do this, what it is. We have the training for it. I have a degree in medical ethics. I've done many years as an ethics consultant. I teach at the Center of Ethics at Harvard, and I've mentored many medical students at Harvard. So I went with that to the bosses and said, well, this is my vision, and I want to create this curriculum. And the next step was, how do we manage it, and how do we interact with the trainees, and how do we build it in their very busy schedule? So we defined our objectives. We conducted a needs assessment. We asked the residents, what do you want to know about ethics? What don't you know? And what does it in your normal practice and daily work that you feel that you're not equipped to do? Then we organize interdisciplinary content. So I bring in a lot of people who are not physicians, who are not anesthesiologists, who are often, we have something called patient liaisons, who are previous ICU patients and families who now volunteer their time with social work to come in and talk to our trainees for the specific purpose of improving their ethical and moral communication and character. And this is their free time. I just buy them coffee and donuts, and that's about it. But very often they can't even come. They are on Zoom. But we bring that in. So once a month we have the families, the residents love hearing we've learned from them, even I've learned so much from them, that talking about a patient when they are not, they're in a coma and sedated on a ventilator, they can still hear you sometimes and they don't like it. Or talking about another patient outside the door can be very distressing when that patient is I had an ECMO patient. We were discussing crashing onto ECMO. We were about to cannulate. And the patient next door who just had a cabbage, just hanging out there watching the game on TV, was petrified. He almost had another MI because he was listening to this horror show going outside, and there were 25 people standing there ready to cannulate. And I went and had to apologize, disclose what was happening, and of course, keeping patient confidentiality. But learned my lesson, and we had to then bring about some guidelines within our ICU behavior and how not to talk about, and we have signs up everywhere, but we just don't do it. So that was something to learn from patients and their families. So I bring in those families, and we do have sessions when they talk. Then we bring in nurses who are, whether they are ethics teachers or not, but we bring them in. We bring in a lot of social workers to talk to our residents on how to discuss family meetings. Social workers sit in on all these family meetings. They can tell you who's a good communicator and who is not. And I often, after a family meeting, go and ask the social worker, how did I do? What did I do wrong? How can I learn? And what did I not get? What, was I reading the room right? Was I talking to the right person who was making the decision? We had a patient who was a 16-year-old moped accident, brain dead. The mother and father had separated, were not on talking terms. The father was the legal, had custody, but it was really the mother who was not letting go. Obviously, she was devastated. It took 3-4 days for them to accept that the boy was brain dead. But she would come in every day. She knew what was happening and wanted to avoid everybody. So she would come in the evenings after everybody left, the attendings. She would avoid everyone, did not want to have the discussion of withdrawal, well, donation in this case, did not want to let go of her boy, would come in and stroke him, anything I would do for my son. Put his favorite toys next to him. It was heartbreaking watching her. So I watched this for 3 days. Meanwhile, we were keeping the organs alive by resuscitating, putting in chest tubes for a pneumothorax that happened, changing the central lines for fevers. We were doing all this knowing this boy was dead. But the father wanted to donate, and he had legal guardianship. We couldn't take the boy and have the mother screaming and crying and devastated. Obviously, that was not the right thing to do. Remember what ought to be done. So one day I decided I'm going to stay back. And I went in when she came. She came in very late, knowing she wanted to avoid everybody. She knew what she was doing. And she wouldn't talk to her husband, who had made the decision, who was the legal guardian. But she came in very late. And I went to talk to her, and she wouldn't talk to me. She's like, I do not want to talk to you. So I just sat down and sat with her for an hour in complete silence. And I was crying because this boy was the same age as my son. And beautiful boy, just lying there, passed away. But anyway, I just sat there with her. And after a while, she reached out to me and hugged me and started crying. She just let go. And it was just that sitting in the sort of, in the sorrow with somebody, sharing that moment, that kind of, she said, I know he's dead. I just don't want to let go. I can't let go. And then I explained to her that, there was terrible injury, there was brain coming out, it was just, his body was deteriorating very fast, and this was not the humane thing to do. But when she saw that I was looking at it from the point of view as a human and not as somebody who wanted something, the distrust, this was a Black family. There is a lot of distrust, at least in Boston where I practice, huge amount of distrust in the healthcare system amongst the underrepresented minorities, Hispanics and Blacks specifically. And my research up till this point wasn't that, but my NIH grant got shelved. So there's a lot of distrust. So breaking that bridge of the distrust was very important, to see that somebody saw your child as a child who could be your child as well. That's important. You can't teach those things. You have to feel them, but you have to give the trainees an avenue to value that feeling. They all have it. We all have it. It's just giving it value. And we chose some instructional methods on how to do this, whether we have actual drills and role play, or we just have lectures, who we bring in. I'm just bringing in an attending who's a GYN, a gynecologist at Harvard, at Brigham, who's written the curriculum for gender-affirming care. And it's a big topic right now. It's very controversial, but the residents are conflicted, and they want someone to talk to them about it. It's a true ethical and moral dilemma, and now a legal dilemma. So we bring in these topics not to create a stir, but to help people reflect on things together with someone who knows the subject matter. And so we're bringing her in. And then we're integrating some virtual reality and AI tools in this as well in our curriculum, so that they can actually see how things could be and how things are. And AI actually is helping a lot in building these scenarios where you can have an AI situation where you're looking at something as if you are there, and in a family situation or a family meeting, etc. Now remember that it's not just the learner, which is the resident in this case, but also the teacher and the knowledge and the learner become one in these kind of curricula, where you are actually learning from the teacher, learning from the learner. And you are the teacher, but you're actually learning so I have modified the curriculum as we have moved, and each lecture gets a note, and then the next time I do that, it's a different lecture because of the input we got from the residents. And they bring in a lot of background, a lot of training. Some of them have done degrees in law or ethics, or they've worked. I had one medical student at Harvard who had done 3 years in a refugee camp in somewhere in South America, and had worked with those people and brought in so much input on how to understand empathy, really understand it. And then you can integrate that into the knowledge that you are disseminating. So we have lectures, journal clubs, debates, case discussions, role play, interprofessional education, bring in guest speakers, past patients and families, stakeholder opinions, interactive sessions. And we take the residents to different units. Like we took them to the PACU, and we asked the nurses, what are the ethical issues that you face? And we had a discussion and a live debate there with the residents. So we go places, not just sit in our lecture and sit in our little ivory tower and think that we know best, because we don't, and everybody says it, so it must be true. We also have OSCEs, because in the ACGME curriculum, now they are tested on this. They have situations where they have to resolve an ethical dilemma, and they have an OSCE on it. So we train them. And then we do longitudinal self-assessments, because like I said, you can't really assess a resident's ethical behavior, but we ask them to assess themselves and tell us how they're improving or not. And then we ask 360 appraisals from peers. We ask nurses, we ask other residents, we ask faculty, we ask medical students how that resident, just like we would assess their intubation technique, how is their ethical behavior in situations. And then they can meet now surgeons have come to us and asked us to be part of this. So we bring in their residents during our ICU lectures, and the surgery residents also bring in their input and their very unique problems that they face. Patient autonomy and advanced directives is another curriculum topic. Cultural humility is very important, especially in consent, especially when you use interpreters. We've learned from patients and their families that we often, even if we don't mean to, we are very arrogant in how we get interpreters to explain something to a patient. Just the other day in PACU, I had a whole list of Chinese-speaking patients who came in, and they spoke different dialects. And there was a lot of eye rolling going on amongst PACU nurses because it was delaying their flow of work. because somebody spoke one dialect, somebody spoke another dialect, couldn't get the iPad to work, blah, blah, blah. But that didn't take away from the fact that this patient had the same problem that an English-speaking patient would have and was coming for the same surgery that anybody else would. So what does that mean in our behavior? There is a bias, and we have to recognize it. So I was just observing this. Of course, wouldn't dare say anything to a PACU nurse, especially in the pre-op area, because you really want to get your day done. So that cultural humility comes with discussing these things in a way that are human and how you would behave in that situation if you were the family or the patient. Again, futility and withdrawal of care, we don't have time to discuss that, but that's something that's my life in the ICU. I work in the ECMO units, and it's a constant. Empathy and communication, and then impaired physician scenarios. This is the Harvard Med School program, which the medical students go through. They talk about equity and anti-racism, professionalism and cultural humility. Up until last year, anti-racism was a very big thing for Harvard, sort of to come to terms with its own history. Community engagement, advocacy and activism, and interprofessional education. So we did the needs assessment, the design of the curriculum, and the instruction. And then we evaluated with feedback and refinement. And these are the actual goals that we tried to achieve: collaboration, communication, empowerment, and then moral development, principles of ethics, and professional behavior. And in conclusion, we really want to be this guy, the trusted doctor. Ethics training is essential, not optional. Residents need structured curricula, and it's a lifelong professional requirement. And framework ensures competence. Why do we need a framework? We need it for competence, for compassion, to build resilience. And I wanted to end with this painting. I don't know, I did my high school in London, and this painting is hanging in the Tate Modern. I don't know if you remember, if you've ever been. It's called The Doctor, simply. It was painted in 1820 by Sir Luke Fildes. And basically, if you look at it closely, it really touched me. I was still in high school, trying to be a doctor or get into med school. But a good doctor possesses a combination of professional skills, personal attributes, and ethical standards that contribute to effective patient care. If you look at this painting, you see a child dying of typhoid. Well, you don't know it's typhoid, but it is. And this doctor is sitting there. And in the background, if you can see, you see a distraught mother with her head on the table, overcome with grief, and the father just standing there comforting her. But look at how far they are from their child, who's minutes away from dying. And there's a sure death. This is typhoid. There was no treatment, and this is pure pre-penicillin. And the doctor is immersed in sitting there and looking at this child and the suffering of that child, trying to see how he can help, and the reverence of the family and the parents to this doctor. You would not see this in this day and age. You wouldn't see this trust, you wouldn't see this reverence. And I'm not saying that we want the adoration of our patients. We just want to be trusted in the decisions that we make. So therefore, I'm trying to make a case for ethics teaching, and I hope that all of you can think about it and go back to your institutions and try and build a case for such training. And I'm sorry that I took so much time with the stories, but any questions that I can answer for you, please? Or comments or your own feelings? I'm sure a lot of you bring a lot of expertise and your time. Yes? Hey, Mike. Yeah. What we've done is built in our longitudinal assessment, like daily assessment in the OR, we've built in a line about ethical and professional conduct from the attendings. I find that when you simulate something, people are on their best behavior. And across the board, whenever I do a drill or a simulation, they do the right thing. The answer is always correct. But in the daily behavior from nurses, from the 360, from the attendings, you find that, no, they cut corners, or they didn't do something in the ICU that they should have, or someone was not compassionate. I know when medical students want a letter, they always want that line or a paragraph on how I went out of my way to spend time with a family or did an extra in showing empathy and compassion. It's very important to them. But it's artificial I feel, if you put them in the spot and ask them to perform it, because they will. But when you observe it without the pressure of being observed, often it's missing. And then you can take them aside and say, but you require emotional intelligence for that kind of feedback. These are adults, we're adult learners. So for me to go up to someone and say, hey, or to even a faculty and say this was unethical behavior, it would put me in a very, very difficult situation, because it's not something our organization is sort of judging them for. They're not getting paid to be ethical. That's the problem with our health. That's why that article by, I encourage you to read it, by Sachin Jain, who I know personally. He's very disenfranchised by how physicians and doctors behave these days, because he believes that we have eroded our moral character to a degree where we don't even know that we have. So self-reflection, reflection on others, but to speak in a way where healthcare leaders will actually reward people who are ethical and then reprimand people who are unethical. We are very far from that. We are not rewarding ethical behavior or reprimanding unethical behavior. Illegal, yes, but not ethical. So I think as a culture, we need to change, but we can start small. And I reward residents, like that resident, the CA1, who made everybody wait an extra 15 minutes to give time to the family. I made that into a huge deal for him. And well, I can't reward anybody, I'm not in that position, but I can at least praise them to a point where people say, oh wow, this is great. And he himself was humble enough to say, stop saying that every time you see me. But I think it's great. We need to put these people on a pedestal where this is great behavior. This is the behavior that your patients want and what you would have wanted when you were writing that essay 10 years earlier. I think we all need to go back to that value that we had and was so important to us. Yes, please.
I was noticing like a lot of what you're talking about is blending ethics and professionalism, which I do think should go together. But often like they can conflict in ways if the professional, like not the stated values, but the actual values of the institution that you're in conflict with what is ethical. So like, for example, pushing back against a surgeon who wants to push through with something might be interpreted as unprofessional, even if it's the ethical thing. Or if I'm sitting in a patient room for an hour with my phone silenced, 12 nurses have tried to contact me in that hour, and all of them think that I'm being professional. With these constraints of the institution that's much more focused on with like throughputs and things like that, we end up creating a professionalism that is unethical. So then trying to evaluate them together becomes difficult, because what is professional is not always what is ethical in the culture of wherever you're at. So I wonder if you could like discuss a bit about how you get at both. If you're putting them both together in the same evaluation, people might interpret it as overvaluing one or the other. Like how do we disentangle these in knowing that in the short term we're not going to get to a point where the professional values of all of our institutions are ethical right now.
Yeah, so you bring up a good point. For me, the ethical behavior is the professional behavior. Whether it's perceived as unprofessional, I think we need to start educating people on what is ethical or not. But then there are limits to how much time you can spend in one situation. In the work we do in the ICU, I'm constantly stretched in many directions. And I have to perform, and I have to finish rounds, and I have to take care of the lines, and I have to cannulate somebody, and I have to move on to the next patient. So balancing that is also ethical, because the other patient has an equal amount of, has that capacity to require your attention as well. So I think what you're saying is that there is a conflict. I think if we look at it from a different lens, the ethical intent is ethical behavior and professional behavior. But to communicate that intent is important. I often apologize. I apologize a lot. And there's nothing wrong in saying to someone, I'm really sorry, but I feel that this patient needs more time. And that person's value, the nurse who's trying to rush you or is annoyed, her own values are speaking, you are speaking to those values. So if we start speaking to each other's values, then professionalism and ethics align. It's just when the conflict arises and we communicate in a way, the bridge between those values is communication and the relationship. Now I'm at a point where people say, oh, it's Shala. It's okay. Whatever she's doing is fine. You have to build that reputation about yourself, that what you're doing is, even if it is bridging, is going over time or is bridging unprofessional behavior, it is not. So when a complaint comes in about me, for example, there was I don't have time, but there was a patient who my nurse moved for a colonoscopy, and they perceived it as being touched inappropriately, and they complained. When it came to the head of QSI, they said, it's Shala, it's fine. I'm sure there was a misunderstanding. And then we explained to them that it was meant as the patient didn't speak the language and things like that. So I think what you're saying is correct, and I'm sorry that this is happening, but I am humble enough to go and apologize constantly, but I stick by my ethical stand, and the residents know it. The residents, the trainees, the medical students, and even the nurses know that I would not compromise my ethics for cultural or organizational norms. I think we all do. We just have to not look at it as something that's compromisable. All the time, all the time. Yeah. Yeah, 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 yeah. My thesis in ethics, when I was doing my PhD, my thesis was on narrative ethics. You narrate a story, and then you learn from the story, and that's the most powerful way of teaching any philosophy. So if you've ever learned a philosophical semester in college, or if you've ever done a course on philosophy, the only way to learn it is from something that is a lived experience. So you're right. I'm going to run because I'm getting bad looks now. Thank you so much for coming. Thank you.